surgery was the first method that we found out that could cure cancer way back in the 1800s. Now, and it continues to remain the cornerstone of breast cancer treatment. I'll share with you two hypothetical patients. The first patient is in stage 1, which means that it's a very early, very small cancer. And if you were to do surgery for this lady, as you can see here in the green line, she will achieve an 84% chance of cure. If you were to add on hormonal therapy, chemotherapy, radiotherapy, and whatnot, you can achieve another 4% additional survival. So, the surgery alone accounts for the majority of cure in such early cases. Now, if we were to flip over to an advanced cancer where the patient is in stage 3, even without any other treatment, surgery will be able to cure about 1 in 5 of such advanced cases with just surgery alone. Of course, if you were to add on hormonal therapy, chemotherapy, and the other adjunctive treatment, the cure rate improves to about 50%. So in Singapore here, we are clearly in the era of de-escalation as we improve on our screening and general population awareness about breast cancer, so much so that about 70% of our cancers here are diagnosed in its early stages. And so if we are diagnosing cancer earlier, is there a possibility that we can give less treatment and yet achieve the same effective disease control? And the answer is yes. And that's the mantra I often preach now, that we are clearly in the era of de-escalation, or what I call less is more. Nowadays, we can't even feel the lump, much less see the lump. So we can oftentimes just do what we call a lumpectomy. As you can see here, there is a tumor, a very, very small tumor that is only seen on X-ray and is marked with a little metal clip there. There is also small little dots here, which are formed because of calcifications, and these also represent non-invasive cancer. So by being very accurately, being very accurate about our surgery, we can remove the tumor with a rim of healthy tissue and preserve the breast at the same time. So in the past, we often thought that lumpectomy, in the past meaning in the last 40 years or so, we always thought that lumpectomy has the equivalent cure rate to that of a mastectomy, especially when radiotherapy is added to lumpectomy. But nowadays, current evidence seems to suggest that perhaps lumpectomy is even more superior than mastectomy. So a bigger operation doesn't give you a better cure rate. So you can see here in a very recent paper, this was published in 2021. So earlier this year, you can see a 5-year survival rate among Swedish ladies who had breast cancer surgery. If they went for lumpectomy, their cure rate at 5 years is 96%, versus a mastectomy, the cure rate is only 91%. So there's a 5% difference in favor of lumpectomy. Well, again, this is a paper that I contributed to, and we wanted to know why was it that in Singapore, despite the fact that we were detecting cancers so much earlier and having such small cancers to deal with, why is it that a lot of our patients still choose to go for mastectomy? So you can see here, just to let you know, in Singapore, like I mentioned to you, 70% of cancers are detected in its early stages, which means that lumpectomy is very suitable, and yet only about half of those patients eventually choose lumpectomy. So what happened to the other half? Why did they choose mastectomy over lumpectomies? We did a survey study here, and we found out that the number one reason why they chose a mastectomy was because of a fear of recurrence. Again, like I've showed you in the previous slide, this is a fake news, right? Mastectomy is not better than lumpectomy. For them, they also value health over cosmesis. Again, I think this is not true. You can have both health and cosmesis. In other words, you can have your cake and eat it at the same time. The only thing that's maybe a little bit true is the possibility of a second surgery, but nowadays with better technique and better know-how, we are able to choose the patients very carefully, do the surgery accurately, and avoid a second surgery most of the time. Interestingly enough, in this group of patients, the mindset is so entrenched. We said that if you were to have a second chance, a second bite at the cherry, would you choose a lumpectomy? Actually, only less than 1 in 5 of such ladies in this survey study would choose a lumpectomy, even if they were given a second chance. So what I'm trying to say is that while we have all these smaller but just as effective surgery, somehow the cultural attitude is so entrenched. I think it will take us years to overcome this. So I want to bring something different that I want to talk about this year compared to last year is that, we are going from bigger operations to smaller operations. Will there ever be a day where we will go from smaller operations to no operations at all? I know this is not something that a surgeon should be saying, but actually this has been something that I've been thinking about for a long time. So whenever I think about this, the song by My Way by Frank Sinatra comes to my mind, because within the lyrics there was a phrase and it says, "And now the end is near and I face the final curtain." So I'm just wondering whether or not it will happen in my lifetime. Just share with you a couple of tantalizing evidence that this could happen in the next 10, 15 years. So the first two studies called Loris and Comet, these are ongoing studies for low-risk screen-detected, meaning low-risk and small non-invasive breast cancer. Non-invasive breast cancer in medical terms is also known as stage 0 cancer or ductal carcinoma in situ. Because DCIS or stage 0 breast cancer do not invade or spread to the rest of the body, they are not known to be life-threatening. So the main danger that comes from DCIS is that if we do not treat it well, it may eventually become an invasive cancer and threaten the patient. So because of the background of screening that has been so prevalent over the last 30 to 40 years, there is a growing concern that actually we are over-diagnosing breast cancer. Some of you in the audience may have heard of that, and that number could be as high as 25%. So the investigators in these two studies, Loris, which is a trial started in UK, Comet is a trial that started by my friend Shelley Huang at Duke in the US. They are looking at non-surgical intervention for the treatment of such stage 0 cancer. So they are comparing standard treatment, which includes surgery, versus just giving the patient hormonal therapy. And the measure, the key measure is then like what I mentioned earlier, that they want to see whether or not for patients who just go on hormonal therapy alone, will that also mitigate the risk of the development of invasive breast cancer? So far, I've not heard any news of any results coming out from this study yet. As you can imagine, it's probably difficult to recruit patients to participate in such a trial. The next trial is even more brave on the part of the investigator and even more so on the part of the patients. And this got to do with very aggressive but very chemosensitive breast cancers. I mentioned these two groups before, and again, they are namely the triple negative cancers as well as the HER2 positive ones. So what happens in this trial is that women are then subjected to chemotherapy because we know that the tumors are very, very sensitive to chemotherapy. We now know about 70% of them disappears completely on chemotherapy by the time we do the surgery for them. So rather than do the surgery, the investigators decided that perhaps in these women, if we can show on breast imaging that we do not see any more cancers, we will just do a needle biopsy, a large bore needle biopsy, taking multiple cores as more than a dozen or more, and if shown on biopsy that there is no more cancer left, then we do not go on to do conventional surgery for them. So this is really, really brave. The endpoint is to look at the 5-year local regional recurrence rate. I mentioned a lot about surgery. Surgery is what we call a local therapy together with radiation therapy. And then we have the other forms of treatment which are given or delivered, and it goes to the rest of the body as well. So this includes hormonal therapy, chemotherapy, and then perhaps something which is less familiar to the audience, something called targeted therapy. So I'll go through each of these in turn. So radiation therapy, like I mentioned to you, just like surgery, is a form of local therapy. Traditionally, you require up to about 6 weeks of radiotherapy that's given on a daily basis. So it was pretty inconvenient, not to mention that there are other side effects, including particularly damage to the heart vessels, especially if the radiotherapy is given to the left chest. Recently, again, we have a de-escalation of radiotherapy in that sense. We can now reduce 6 weeks of radiotherapy to just 1 or 2 weeks, especially for early cancers. And this is from the Fast Forward trial, which was published sometime last year. Hormonal therapy is something that is quite unique when it comes to treatment of cancer, because most cancers do not have this option. But the reason why breast cancer can be treated with hormonal therapy is that, in fact, the majority of breast cancers, 70%, is driven by the growth is driven by the female hormones, in particular estrogen. So we can then deploy drugs which block the effective or the effects of these hormones, estrogen and progesterone, on the cancer cell, and thereby reducing the chance of recurrence by up to about half the time. So the key drug that we used to use for a very long time was something called tamoxifen. We now have ever newer agents, including aromatase inhibitors, and for patients with advanced cancers, we then deploy something which is just came out in the last few years, but it's a big game changer, called CDK4/6 inhibitors. The downside to such treatment, although it can be taken orally, is that it has to be given up to about 10 years, so very, very long. And also there are quite a bit of side effects, especially in the initial period where treatment is started. And these are most commonly menopausal symptoms such as hot flushes, mood swings, sometimes even a bit of hair loss and weight gain, things that generally women really don't like. Okay, so chemotherapy is perhaps the most dreaded of all treatment types. Everybody understands about surgery. Some people know that radiotherapy is not so bad, but every time you talk about chemotherapy, the first thing my patients will tell me is that, can I avoid this or not? So chemotherapy is still, by and large, very effective for breast cancers. Oftentimes, when we give chemotherapy for breast cancers, we don't deliver as a single drug, unlike for some other cancer types, but rather we use it in combination. So usually 2 or even more drugs given at the same time over a period of between 3 to 6 months. And the main reasons why people don't like chemotherapy is because of the considerable side effects. So this includes immunosuppression, damage to the heart, damage to the nerves, not to mention things that also that is aesthetically not pleasing, such as hair loss and nail changes. But thankfully, these are all temporary side effects. Now, I put up this picture of MMMs here to remind me, and also to let the audience know that in the past, we used to be very, very strict about who we give chemotherapy to. And you won't believe that anybody who has a tumor the size of an MMM, which measures 1.1 centimeters in diameter, I checked this out on Google, so it has to be correct. Any tumors 1.1 centimeters and beyond, we should be thinking about giving chemotherapy. But thankfully, this is in the past. We nowadays can employ tests such as genomic tests this is the era of what we call personalized medicine. And so in the same spirit, we can use genomic tests to test whether or not we can safely avoid chemotherapy when it comes to early breast cancers. So for example, if the patient is above 50 years old, by employing a test called Oncotype DX, when the score is 25 and below, the patient do not need chemotherapy. Only if the score returns as 26 and above, then would they benefit from chemotherapy. By employing such tests, I can share with you that for up to about 70% of my patients whom I deem eligible for this test, they were able to safely avoid chemotherapy. 20 to 25% of all breast cancers overexpress this target called HER2 receptors or on the cell surface. And nowadays we have monoclonal antibodies, so specifically made antibodies that target this HER2 only and spare all other cells. So they don't work like chemotherapy, which is more like blanket bombing. They zoom in on HER2 positive cells only. So they work very much in the same vein like magic bullets. And so we have now a plethora of drugs that we can employ to deal with HER2 positive disease. And this has completely changed the cure rates for such HER2 positive tumors. It is because of its very targeted approach. It is also far more tolerable than chemotherapy, but unfortunately, it requires oftentimes a very long course of treatment of up to 1 year. The other thing that perhaps we should know about this is that it doesn't work very well on its own. Perhaps in the future, we can use it on its own without the need for chemotherapy, but at this point in time, we still need to give targeted therapy together with chemotherapy for the best effects. Well, maybe in a one sentence answer would be do what your doctors tell you to do. But really, it's all about risk mitigation. I think if you are, hopefully you'll be compliant to the treatments that have been instituted to you by not just the surgeon, but literally the team of doctors that look after you, because oftentimes now treating breast cancer is a team effort. The surgeon is just one of the few team players. The others, obviously, the medical oncologist as well as the radiation oncologist. Now, the other thing that you can definitely help yourself with is that even if you are many years, and I guess this is relevant to this question, even if you are many years off from your initial diagnosis and you are already off medical treatment, the longest probably is hormonal therapy, but let's say you are already past the 5 years and no longer on hormonal therapy, I think you should continue at least to do a yearly surveillance. I didn't share with you another paper or another line of research which I did, which was to look at the second cancer that happens in patients who already have one cancer. And what we shown in that study was very clear. For women who continue to be compliant with the surveillance, most of the time, I would say virtually all the time, the second cancer is smaller and of a less aggressive type than the original tumor.